Hello and welcome to Falcon Physician Review's Pharmacology online section for USMLE Step 1. My name is Mike Broman. I have a PhD in pharmacology and I'm a cardiology fellow. This first section is entitled Principles of Pharmacology. In this section we'll be going over pharmacokinetics and many other topics that are similar to many types of drugs you'll be seeing in this section. Just some basic practical points for Step 1 before we get started. Step 1 of the boards will only use generic drug names, so it's very important that you remember not only the trade name of the drug for your future practice, but as well as the generic name. Step 1 also focuses heavily on the mechanism of action of medications, as well as adverse effects, especially the unique ones, and we'll talk about those as we go. Some concepts in Step 1 that are heavily tested are autonomics, antibiotics, and central nervous system cardiac drugs. Those are the most tested categories of medications on this test. There are some areas that are becoming more and more popular for questions on the test, and that includes organisms that are antibiotic resistant, drug-drug interactions, as well as pharmacogenomics, which is genetic variation of drug response, and we'll talk a little bit about those as we go. It's also important to remember that drugs that have come about in the last 5 years are not as heavily tested as those which are very well established. The first concept that we'll talk about is pharmacodynamics. Pharmacodynamics basically just defined as how the drug works. Pharmacokinetics, however, is involved with what happens to the drug after it is administered. Pharmacokinetics concerns processes of absorption, distribution, metabolism, and excretion of the medication after it enters the patient. Many medications after they enter the patient are ionized, and medications that are weak acids or weak bases are able to be ionized, which confers a charge upon that medication. Ionization is not an issue for drugs that are neither acids nor bases. Drugs are ionized or non-ionized depending on the pH of the environment that they are currently in. And remember, different compartments of the body have different pHs at any given time. Every drug has its own pKa. And the pKa is defined as the pH at which the molecule is 50% ionized and 50% non-ionized. pKa is specific for a medication. They will give you the pKa of the medication on the test. It's important to remember that only the uncharged form of the drug is able to cross a biomembrane, unless that drug has a specific transporter. The ionized form of the drug is water-soluble. We generated this table from the Henderson-Hasselbalch equation. What this table is meant to show you is if you take the value of the pKa and subtract it from the pH of the environment that the drug is currently in, you'll receive an integer value. If the pH of the environment of the drug is equal to the pKa, then this value is equal to 0. And 50% of the drug is non-ionized, and 50% is ionized. We can classify drugs that have these charges into the category of a weak acid or a weak base. And as you can see, as pH increases, meaning the pH minus pKa value becomes more positive, for weak acids, the non-ionized percentage becomes 0.1%. Whereas if the pH were to become more negative, the non-ionized percentage would be 99%. And this makes sense, because as the pH goes up for a weak acid, it would lose its charge, and therefore become non-ionized. The opposite is true for weak bases, and we'll talk about this more. Drug X is a weak base with a pKa of 8.0. What percentage of that drug will be in the ionized form in the urine at a pH of 7.0? Remember that drugs that are weak bases, in general, because of their drug backbone, have an NH2 group. That's what makes them a weak base. In acidic conditions, there's a lot of H+ around, and that H+, if it's present in great amounts, is able to bind this nitrogen molecule. When that happens, the drug becomes positively charged. That would be the ionized form of the weak base. For weak acids, you don't have this NH2 group. Instead, you have a carboxylic acid group. And when there's a lot of H+ around in acidic conditions, that H+ is able to bind to the O and make the non-ionized form with a charge of 0. Therefore, an acidic condition has the opposite effect on weak bases that it does on weak acids. Getting back to the question, if the pH is currently 7 and the pKa is 8, that gives you an integer value of -1. So if we go back to the previous slide, because drug X is a weak base, we'll have to use the bottom row, and the integer value is -1 from that question. Therefore, 10% of that drug will be non-ionized. So therefore, 90% would be ionized. The importance of this question is that many medications will be charged or not charged based upon the pH of the environment that they're in. And certain medications are more soluble in acidic conditions than others. Local anesthetics, for example, are weak bases. For example, this would include lidocaine. Their pKa values are approximately 8 to 9. At a physiologic pH of 7, about 1 to 10% of the molecules will be non-ionized and able to cross into the nerve to do their job. But in an infected tissue, where sometimes the pH can become much lower, more acidic, less than 0.1% of the molecules will be non-ionized, making it very water-soluble, not able to cross the nerve membrane, and that tissue would be difficult to anesthetize. So some key points on ionization and renal clearance. Both ionized and non-ionized forms of drugs are able to get into the glomerulus, into the kidney, and into the bloodstream. But only the non-ionized forms, meaning the forms that are not charged, can passively diffuse back across the renal tubule membranes and into the venous circulation. Ionized forms of drugs are trapped in the filtrate and are therefore excreted into the urine. We take advantage of this in managing some drug overdoses that we will talk about. Alkalinization of the urine is a concept that we commonly use in the emergency room. By giving a patient sodium bicarbonate, we can increase the ionization of weak acids. Any drug that's a weak acid, if you give the patient sodium bicarb, we will increase the renal elimination of that medication, which is very important in managing aspirin overdose. We're also able to remove elevated levels of uric acid from patients that are having gout crisis or tumor blast crisis or tumor lysis syndrome. We can acidify the urine, for example, with cranberry juice, which will increase the ionization of weak bases and increase their renal elimination. However, this method is very rarely used clinically. Absorption of drugs concerns the processes of entry of the drug into the circulation from where it's administered. There are many different routes of absorption. Some routes are better than others for certain medications. The most commonly given route is obviously the oral route. We can also do parenteral, meaning outside the enteral system or the GI system, using intravenous, intramuscular, or intranasal passageways. We can give some medications rectally or sublingually, subcutaneously, or also into the cerebrospinal fluid or intrathecally. The first pass effect is defined as the ability of the liver to degrade medications when they are given through the oral and the rectal routes. Both of these routes lead to the drug hitting the liver through the portal vein first. Obviously, the oral route causes much more of a first pass effect than the rectal route. The rectum is supplied by both systemic veins and by portal veins. Therefore, only about half of the medications that are administered per rectum enter the portal system and are therefore distributed to the liver. However, for orally administered medications, almost 100% of those medications will reach the liver. The liver, because of its positioning, is able to metabolize medications before they reach the systemic circulation. This brings about the concept of bioavailability. Bioavailability is the percentage of the drug given that reaches the systemic circulation following oral administration. In order to determine bioavailability, we use the area under the curve. That's what AUC stands for, area under the curve. If the drug were to be injected directly into the bloodstream, we would consider that to be the AUC injected. If we were to give the drug orally, obviously the area under the curve for that drug would be lower because the liver is able to metabolize the drug before it reaches the systemic circulation. The bioavailability is defined as the area under the curve orally divided by the area under the curve injected times 100. If a drug is bioequivalent, then the two formulations of the same compound, one, for example, being a brand name drug and another one being the generic form of the drug, if they have the same bioavailability and the same rate of absorption, they are considered bioequivalent. For drugs with a low therapeutic index, meaning medications that it's very easy to become toxic on, for example, warfarin and digoxin, it's best to stay with the same formulation, meaning if the patient takes a generic form, they should stay on the generic form and not switch to the brand name. Because even between the generic and the brand name, you can still have some major differences. Some drugs will interact with certain foods and drinks that the patient will consume. The classic example of absorption and drug-food interactions would be reduction of tetracycline absorption, which is an antibiotic, by milk or antacids. Tetracycline, because of its structure, is able to chelate cations such as calcium, magnesium, or aluminum. And when this happens, the complex is non-absorbable. So therefore, patients that are taking tetracycline should not take milk or antacids along with their medication. Another example is patients that are taking warfarin should not use bile acid binding resins such as cholestyramine. This medication can decrease the absorption of warfarin. As we stated before, the plasma concentration of tetracycline after administration by mouth is normally right here at the top. However, when patients are drinking milk or antacids along with the tetracycline, the concentration can be severely diminished, and this can lead to the medication not working properly. The next concept is distribution. A drug is distributed from the systemic circulation to organs and tissues. Normally, a medication is not active when it's in the systemic circulation. It has to go to organs and tissues in order to do its job. This distribution is influenced by many factors, including the ability of the drug to permeate the membrane barrier, the solubility of the medication, and we've already touched on this in terms of ionization, the rate of the blood flow to the target tissue. If a target tissue has a compromised blood flow, then that medication will not reach the target tissue. And then binding of the drug to plasma proteins. A drug that is very highly plasma protein bound will have a difficult time reaching target tissues as compared to a drug that is freely floating in the plasma. The distribution phase of a drug involves a decrease in the serum concentration to a steady state. The flat line here in this chart shows that over time, the concentration of a medication in the serum will come down and reach a steady state and then eventually taper off as it is metabolized. The distribution phase involves the drug distributing itself to different organs and tissues outside the plasma. Some barriers to distribution involve the placenta. For example, the placenta, which feeds oxygen and nutrients to the developing fetus in a pregnant woman, is a barrier to most large molecules. An example of this would be heparin. Heparin is a very large molecule, very charged molecule, and it's not able to cross the placenta. However, most small molecular weight drugs are able to cross the placenta, especially those that are lipophilic or lipid-soluble. The same thing is true for the blood-brain barrier. Lipid-soluble drugs are able to cross quite nicely into the brain. However, very charged particles are not able to cross the blood-brain barrier. While some medications do not bind at all to plasma proteins, such as albumin, some medications are very strongly bound to plasma proteins. It's important to remember that only the unbound fraction in the plasma is actually able to leave the plasma and activate receptors. Therefore, drugs that are very highly plasma protein bound, such as dilantin or phenytoin, must first become unbound to the plasma protein, and this can be a very slow process. It's also important to remember that certain medications will interact with other medications for the binding sites on these plasma proteins. This may increase the free fraction of the medication because it's unable to bind to the plasma protein. For example, some sulfa drugs or sulfonamides can displace unconjugated bilirubin, which is not a drug, but it is a chemical found in the blood, from plasma protein binding sites, which will increase the risk of neonatal hyperbilirubinemia or kernicterus. Aspirin is also able to displace warfarin or Coumadin from plasma protein binding sites, which is the reason that many of these medications are not commonly given together. For example, Coumadin and aspirin are not usually given together. The concept of volume of distribution, which is a false value, is an apparent volume of distribution. Remember, this is not a real volume, but an apparent volume. It's a pharmacokinetic parameter that correlates the dose that's given with the resultant plasma level. Every drug has its own volume of distribution, and this value will be given to you on the test. A lot of times the volume of distribution will be liters per kilogram, and they will give you the kilograms of the patient. So you will be able to calculate the volume of distribution, or they will simply give it to you on the test. The volume of distribution is simply the dose that's given to the patient, let's say it's 100 milligrams, over the concentration at time 0. This should be a steady state concentration, meaning after the drug has had time to distribute. The concept of volume of distribution is shown here. If you have drug A and you give it to a certain volume, it's the amount of the drug that you gave over the volume that's apparently in. As we rearrange this formula, the volume of distribution, which is here, is equal to the dose divided by the concentration in the blood measured at the steady state. Why is volume of distribution important? Remember that volume of distribution, which is expressed either as a unit of volume or volume over weight, is important for dosing medications. We can calculate the volume of distribution by using the dose if we know the plasma concentration after the patient receives the dose. For some medications, the calculated volume of distribution corresponds to the compartment that the drug distributes into. For example, for a 70 kilogram person, the plasma compartment is equal to 3 liters of water, whereas the whole blood compartment is equal to 5 liters of water, because the whole blood compartment also involves the red blood cells and the white blood cells, which take up volume in and of themselves. The extracellular fluid compartment, which also involves tissue fluid, is 12 to 14 liters, and the total body water compartment is equal to 40 or 42 liters. If a medication is able to enter only the plasma compartment, then its volume of distribution will be approximately 3 liters. Whereas if the medication is able to get into the entire total body water compartment, then its volume of distribution will equal approximately 40 liters. Here are some examples of selected drugs. For example, heparin, which is able to enter the plasma compartment, the volume of distribution is 3 liters. For warfarin, which is able to get into the entire blood compartment, its volume of distribution is 5 liters. For theophylline, the volume of distribution is 12 to 14 liters, and for ethanol, or drinking alcohol, the total body water is involved, and therefore the volume of distribution is quite high. And the reason this is so is because ethanol is a very small drug that goes easily into all water compartments. Here's some other examples of volume of distribution. Chloroquine, which has a volume of distribution of 200 liters per kilogram, nortriptyline, 20 liters per kilogram, all the way down to warfarin, 0.1 liter per kilogram. Drugs with very high apparent volume of distribution bind extensively in tissues. Because the drug has a small amount left in the plasma, it makes it appear or look like the drug has distributed into a very large volume of water, whereas in actuality it's bound to tissues and therefore the plasma concentration is very low, which will raise the volume of distribution. Remember that volume of distribution is a false value. What it represents is how well the drug is able to distribute into the body. An important concept for the boards as well is redistribution of medications that are lipid soluble. A perfect example of this would be the intravenous general anesthetics. This concept is seen with especially medications such as thiopental and propofol, which are the most commonly given intravenous general anesthetics. These medications work by first distributing to organs with high blood flow, such as the brain, and this is generally considered the target tissue for these IV anesthetics. After the medication has distributed to the organs with a high blood flow, the medications then will redistribute to other tissues, such as muscle and fat. When the administration of the drug is stopped, then the redistribution causes the brain level of the medications to drop and the patient will come out of anesthesia. As you give more and more of the medication, it will accumulate more in the fat compartment of the body. This is a diagram showing concentration of the drug or percentage of the dose of the drug over time. And you can see that in the beginning, the medication, if it's an intravenous anesthetic, will be mostly in the bloodstream, and that will diminish over time. The next compartment to receive the drug over time is the vessel-rich group, like we were talking about the brain and liver. The next compartment to receive the drug is the muscle group, and then after that, the fat-rich group will take over for the medication. Certain medications, such as thiopental, have a hangover effect, quote-unquote. As the drug leaches out of the tissue depot, that can take a long time, and therefore patients that are obese or have a high fat component will have a more difficult time coming out of anesthesia with propofol and thiopental because of the accumulated drug in the adipose tissue. And you can see here over time, after thiopental is stopped, the plasma levels will drop quickly, and yet over time will slow down because this represents the drug coming out of the fat compartment back into the plasma. This is the last slide in this section. This is the last slide in this section.